I think this is something we've been hearing a lot about over the last, let's say, 2 to 3 years. And I'm sure all of you are taking or thinking about it whenever you're doing a sleeve for a young patient. And is there really any evidence that by doing so, are we hurting them in the long term in terms of, are we really increasing the risk of esophageal or gastric cancer? So my disclosure, I'm actually a surgical oncologist who has done 2 fellowships. I've done an MIS bariatric fellowship and also a surgical oncology fellowship. So basically, still most of my cases are surgical oncology. I do some bariatrics to maintain my laparoscopic skills for complex reconstructions, mainly sleeves, some bypasses, and a few revisionals, bands to sleeves. The other thing I really liked, Dr. Bassem Safadi talked this morning about how surgical oncologist and bariatric surgeon could really form a team. And actually, this is the kind of team that we're talking about. There's really not much harmony between oncologists and bariatric surgeons, although I think as a bariatric surgeons, we are doing a great job in preventing cancer down the road. When you search Google for esophageal adenocarcinoma post-bariatrics, basically, this is what you found. This is a talk by Dr. Rutledge. Making it so easy is that when you do sleeves, basically you get GERD and then you get cancer. And I hope medicine is as simple as that, basically. And I'm sure those of you who are on Facebook, the International Bariatric Clubs, that's 2 days ago, November 5, Dr. Rupiero had posted this very interesting case about esophageal adenocarcinoma after sleeve in a patient who had Barrett's before sleeve, and they know that they had Barrett's because of the case, they ended up doing sleeve for this patient. They could not do a bypass because of his complex surgical history. And if you see Dr. Khalid Jawdat and Dr. Muhammad Abu Zaid are the 2 guys who, the first one who did likes for this case. Basically, they were supposed to be busy preparing for this conference, but they were on Facebook. Now we found them. And if you look at the comments, Dr. Harris was here. He's actually the moderator of the IABC. So he invited Dr. Rutledge to comment on this in this post. And you can see Rutledge, again, he's simplifying medicine, reflux, esophagitis, Barrett's, metaplasia, and risk of cancer. I think we have to think about Barrett's actually is a metaplasia. So basically the definition of Barrett's is metaplasia. So maybe we have to remind him that it actually dysplasia comes after Barrett's and then risk of cancer. And then again, he does it the same thing. And then Patrick Newell respond to him. Basically, we have all these discussions. Very interesting. If you are not a member of IBC, I would strongly on Facebook. There are very interesting discussions happening on that forum. So let's go to the facts. Let's go to science. What we really know about gastric and esophageal cancer post-gastric surgery. So we know that risk of gastric stomach cancer after a gastrectomy for peptic ulcer disease, regardless mainly of the B2 reconstruction, there's a 3 to 4-fold increase in gastric stomach cancer. In terms of esophageal adenocarcinoma post peptic ulcer disease surgery, there is no evidence that there is an increase in the esophageal adenocarcinoma post benign gastrectomy for benign conditions. And there were 2 very nice papers published on this for a very long-term follow-up cases. What we really know also, that's even proven, that the incidence of gastric adenocarcinoma is decreasing, and thanks for the H. pylori eradication. And the incidence of esophageal adenocarcinoma is increasing worldwide, and that is very well documented. There's a lot of blames of obesity being the #1 or the main cause of increasing in esophageal adenocarcinoma. We know that GERD is a major risk factor for Barrett's that can lead to esophageal adenocarcinoma. Barrett's, we know it is the precursor for esophageal adenocarcinoma. And we know that obesity is a major risk factor for GERD, Barrett's, and esophageal adenocarcinoma. If you can see, this is the International Institute of Cancer Research. The evidence is convincing of that body fatness results in a higher incidence of esophageal adenocarcinoma. So there's no questions about it. The other thing is it really obesity what's causing this increased risk of esophageal adenocarcinoma? Very nice epidemiological paper that looked at the impact of obesity in terms of what's the effect of obesity on this trend. They actually put two scenarios. One, they postulated scenario one, as you can see here, that the obesity prevalence will be the same over the years from 1975 to 2005. And this is the impact actually of obesity in esophageal adenocarcinoma. If they look at the increasing prevalence of obesity scenario two, this is how much it would affect the incidence of esophageal adenocarcinoma. But if you look at the SEER database, this is actually the actual incidence of esophageal adenocarcinoma. So the thing is actually it is more complex than, it's not progressing. It's not progressing. So it's not progressing. So again, we know it is actually reflux, tobacco smoking, alcohol. These are the other risk factors that we are aware of. And basically, this is just descriptions of how much GERD is actually increasing the risk of esophageal adenocarcinoma. You can see here this is the esophageal adenocarcinoma in white men. Basically, you can see this is with patients who are reporting weekly symptoms of reflux. And you can see this is where they're reporting daily symptoms of reflux. And you can see the esophageal adenocarcinoma risk in women in general is very low. Basically, this is something we have to understand, that it's mainly a men problem rather than a female problem. And in terms of reflux post-bariatric surgery, we were all aware of Dr. Ginkgo paper about the Barrett's rate after sleeve gastrectomy as something concerning, even in patients without symptoms. And this is, again, to add to the controversy, we know this is the wide variation of GERD symptoms post-sleeve, so there's no consistent data. So what we know in terms of bariatric surgery and GERD, that restrictive bariatric operations may increase the risk of de novo GERD and new insert Barrett's. And then Roux-en-Y gastric bypass is an effective treatment for GERD in obese patients, and actually it may result in regression. If you want to learn more, Dr. Akari had talked about it, and Dr. Bashir is talking about it tomorrow. So questions for the groups here, or what I'm trying to answer, since obesity is a major risk factor for GERD, Barrett's, and esophageal adenocarcinoma, then treating obesity would decrease the incidence of esophageal adenocarcinoma. That's the first question that I'm going to try to answer. And then since restrictive bariatric operations may increase the incidence of GERD and Barrett's, and maybe then it will increase the risk of esophageal adenocarcinoma. Is this true or false? If you look at the literature, there's actually two main population-based studies. This is from Sweden that they looked. It's not the SOS. Actually, this is just a population-based studies from Sweden. And if they look at they looked at patients who had bariatric surgery, 34,000 patients, compared to 123,000 patients who had no surgery. They're obese without bariatric surgery. If you see, they tried to match them as much as possible, but you can see the ages did not match well, and there are more males in the non-surgery group compared to the surgery group. And if you look at the number of cases that were diagnosed, only 8 cases of esophageal adenocarcinoma in the obesity group, and 53 cases in the non-obesity group. Basically, there were no statistical difference between the two groups in terms of risk of esophageal adenocarcinoma. The majority of these cases were gastric bypass, 74%, but quite good number of restrictive operations, including BBG and gastric banding, as you can see here. These are the 8 cases who had esophageal adenocarcinoma post bariatric surgery. You can see 2 with open VBG, 4 with banding, and only 2 with bypasses. And if you look at the incidence, actually this is after restrictive operation. For the restrictive is 3.9 per 100,000 population. For the gastric bypass, 2 per 100,000 person per year visit. And for patients with For patients with, sorry, I'm almost done. For patients with overall population, it's 5.4. So basically, they conclude that. So they conclude that basically, if you adjust for age, sex, gender, and period, the hazard ratio for esophageal adenocarcinoma post-bariatric surgery, it was not different. And basically, this is, again, it did not decrease, at the same time did not increase the risk of esophageal adenocarcinoma. The second population-based studies from the United States of America, from an insurance-based 10-year follow-up data, you can see most of the cases were gastric bypass. Again, there's sleeves here, almost 6,000 cases of sleeve and 1,200 cases of bands. These were followed for 10 years. And you can see the risk of obesity, all cancers were significantly lower for those who had bariatric surgery compared to those who did not have bariatric surgery. This difference was more significant for obesity-related cancer and even for non-obesity-related cancer. If you look at the hazard ratio, was very significant for all patients and for all females. So females, all type of cancer, obesity-related cancer, and non-obesity-related cancer in the bariatric surgery group, there's a great benefit. There is much less benefit for males who had bariatric surgery in terms of cancer prevention. If you look at the esophageal adenocarcinoma, there were like no cases among the bariatric surgery group. Again, 10 years follow-up, 6,000 sleeve and 1,200 cases of bands. There were no single esophageal cancer was diagnosed in these patients, but there were 16 cases in the general population, and this was statistically significant. So according to this paper, from a population-based paper from the United States, there's a decreased incidence of esophageal adenocarcinoma after bariatric surgery. So to answer question one, treating obesity would help decreasing the incidence of esophageal adenocarcinoma. It may actually decrease, but at the same time, we know that it did not increase the risk based on these two population-based studies. Again, this is 16,000 cases. They were restrictive operations that were followed from 3 to 10 years follow-up, and again, no cases of significant increase or increase in the esophageal adenocarcinoma. If you look at the data out there, there are multiple case reports. I did really work hard in summarizing these case reports in these two tables. In terms of esophageal adenocarcinoma, there are a total of 42 cases reported, 17 after Roux-en-Y gastric bypass, 17 after bands, and 4 after VBGs, none after mini gastric bypass so far. If you look at the male to female ratio, it's been always a male disease. The reverse in the ratio, you can find it in the sleeve, where more females were diagnosed with esophageal adenocarcinoma. There are only 4 cases reported. The age, as you can see, ranging from 40, the lowest in the band, to 74 in patients with BBGs. Time from diagnosis, we are all aware of the case that were diagnosed 2 months for the sleeve, but majority of the cases were diagnosed beyond 1 year. For the sleeves patients, basically 4 cases, only 1 with normal preoperative EGD, 1 with preoperative birth that we were aware of it, and then these 2 cases did not have preoperative EGDs. Again, most of these cases, 25 out of 42, were still non-metastatic at the time of diagnosis. So again, this is the summary of the esophageal. And in terms of gastric, this is the gastric adenocarcinoma, 31 cases. Basically 12 after Roux-en-Y gastric bypass, 3 after sleeve, 3 after band, 1 after mini gastric bypass, 8 after a VBG, and 4 after Mason loop gastric bypass. Male to female ratio, again, you see more females for the gastric adenocarcinoma than males, and the sleeves were females. Age, actually, the longest age was in the bands, 37, but most of them are beyond 40. The time of diagnosis, this is ranging from 9 months to 27 years. In terms of the site of the tumor, proximal pouch for the Roux-en-Y in 2 cases, the JJ anastomosis in 2 cases, and the excluded stomach in 8 cases. For the sleeves, they were all in the distal stomach. For the band, cardia and lesser curve and the site of, and also 1 case of erosion. For the mini gastric bypass, the reported case was just in the excluded stomach. For the VBG, 4 cases in the pouch, distal stomach 3, and 1 case of linitis plastica. For the loop gastric bypass, 1 in the pouch and 3 in the excluded stomach. Again, majority were non-metastatic at the time of diagnosis. Okay, just to summarize, is this really these 3 cases or 4 cases of esophageal adenocarcinoma after bariatric surgery are really the tip of the iceberg? We really have to understand that carcinogenesis is much, much more complex than just simple GERD, Barrett's, and then basically esophageal cancer. There's so much, cofactors, genetics, environmental exposure, and toxins that really participate in the carcinogenesis. Although obesity, GERD, and Barrett's play a central role, but there are so many other factors that really promote cancer. What you have to know that Barrett's without dysplasia, which most of the cases in the esophageal in Dr. Ginkgo's study had a very, very low rate of conversion. Once you have dysplasia, you have really to be aware of this. We have done so many cases out there since 1980s, and so far did not really find any significant increase in the risk of esophageal adenocarcinoma. So to answer the question of the topic, do we really have to worry? I believe we should always keep it in our mind all the time. We have to better understand the risk of GERD and Barrett's post-sleeves. You should have really an aggressive screening for GERD and Barrett's pre-op with questionnaires, EGDs, biopsies, 24, whatever works for you. And then really you have to do a post-op surveillance for your patient at this time. And if this association is true, I hope I'm not the one who will be taking care of this group of patients. And then obesity is a major cause of cancer. And I think by doing bariatric surgery, the amount of benefits for these patients in terms of cancer prevention is much, much higher than than causing cancer. And thank you.
Thank you. Thank you very much for this very comprehensive review. And I know you're gonna have to catch a plane. So if anybody has a quick comment or question, we can take that. If not, we can move on. Yep, Aminu.
Okay, now it's okay. There is one case of one anastomosis gastric bypass cancer in the pouch that will be soon published by Italian surgeon Marco Anselmino. It is approved by SORD, and we will have very soon this case. And my question is exactly about one anastomosis gastric bypass, because there is a lot of controversy about the potential oncogenesis of this procedure. Regarding the bile reflux in the stomach and going to the esophagus. What do you think?
So, I think we just have to learn from history. And I think Dr. Mason looped gastric bypass patient had very high risk of, let's say, bile reflux and maybe esophagitis and metaplasia. But if you look at the published data, there is no really much increased risk of oncogenesis or carcinogenesis. I think it might ended up having higher incidence of pouch adenocarcinoma from the reflux, maybe. But again, what we really have to listen at the end of the day is for the data. This is a very large population-based data for very well prospectively maintained databases. And again, we don't have an increased incidence. And I'm sure some of the surgeons here are old enough to realize how many bands, how many VBGs were done. And again, we don't have in the literature any evidence that doing these restrictive operations would really result in increasing risk of cancer. But we have strong evidence that by losing weight and getting the obesity away, that the incidence of cancer, all type of cancers, obesity-related cancers, are much less in this group of patients compared to obese patients who did not have surgery. So as a bariatric surgeons, we really have a great role in cancer prevention that we have really to highlight when we never sell our services to patients, societies, and communities.
Thank you very much. Osama, have a safe flight home, and thank you very much.
Thank you very much. Thank
We'll
you very
move-
much.